I'm Kateri Champagne. I'm very pleased to be here today to present on sleep apnea, and hypermobility syndromes. I'm a chest physician and sleep physician, and today we'll discuss the princess and the pea. I have no disclosures to make. This presentation is based on the best evidence found at the end of September 2023. However, medical literature will evolve, so it's subject to changes without notices. This presentation does not replace the need to obtain the opinion of a medical expert, a physician, a healthcare provider. This is an unpublished review. You may use it for your personal use, but please do not copy or distribute. The Princess and the Pea. Legend has it that once upon a time, there was a prince who couldn't find a perfect princess. On a stormy night, a lady claiming to be a princess, drenched with rain, knocked on their door begging to sleep over. The queen wondered whether she was a real princess and inserted a single dry pea under 20 layers of mattresses. The following day, the lady claimed that she had not slept at all because there was something hard in her bed that prevented her to sleep. On top of that, she was covered with bruises. The royal family knew then that she was indeed a real princess, for only a princess could be so delicate. It goes on to say that the prince married that princess. But one has to wonder whether that princess had Ehlers-Danlos or Hypermobility Spectrum Disorder. So we'll try today to elucidate what happened to the princess and her sleep. So we'll start with the end in mind and begin with the conclusions. So poor sleep and fatigue are two of the three core complaints of EDS and hypermobility syndrome disorders. Sleep disorders and dysautonomia are often associated, and as we move along the literature, more and more disorders are associated with dysautonomia. Obstructive sleep apnea, often I'll just mention sleep apnea, is 5 to 6 times more common in the population of Ehlers-Danlos or hypermobility syndrome disorder than in the general population. Among those with Ehlers-Danlos syndrome or hypermobility disorder, 1 in 3 will have obstructive sleep apnea. Sleep apnea in women is little known and little recognized by physicians and nurse practitioners. In-lab sleep testing is preferred over home sleep testing in this population. Treatment is not with medication. It is using compressed air. And there are several sleep disorders that are relevant to this population. So first, we'll look into sleep and sleep disturbances, a few basic notions about sleep. So healthy sleep should help you restore your energy. You feel restored, refreshed in the morning, and you should have enough energy to go through your day without the need to nap. It also helps the brain function better because the brain has to get rid of the unnecessary memories and do a cleanup of the hard drive every single night, also getting rid of brain waste. Sleep also helps regulate emotion and become less irritable, impatient, and also happier. There are less depressed people if sleep is healthier. Sleep is not a steady state. It does progress by cycles, and there are different subtypes of sleep through the night. This is a drawing of a hypnogram, which means a summary of the 8 hours of sleep or about 8 hours in bed. And in red, we see REM sleep, where we have the most vivid dreams. After every single REM, we're supposed to have a short awakening and then go back to mild or superficial sleep, deeper sleep, and again in dream sleep. This patient has abnormal sleep, so we'll not use this for a comparison. However, many a patient believe that sleep should be continuous, that they should never wake up. The reality is that we wake up 3 to 5 times per night, every night. We estimate that we should not have more than 30 minutes awake per night, but sleep is not continuous. We should fall asleep in about 8 to 40 minutes. If we fall asleep really too soon or anytime, anywhere, it's not normal. That means sleep is not normal. If it takes too much time, it's not normal either. Normal sleep is very individualized. Some patients, some individuals in the general population will feel perfectly healthy and energetic through the day with only 5 hours of sleep, and others might go up to 10 hours. So normal goes from 5 to 10 hours. The average is 7 hours for men and 8 hours for women, but your personal needs might be anywhere between 5 and 10. Sleep can be disturbed, non-restorative, so you don't feel refreshed in the morning, poor quality, for many a reason among patients with EDS or HSD. Beginning at 5 o'clock, medical and psychiatric conditions. There are many conditions that do affect quality of sleep, and those are not unique to Ehlers-Danlos and HSD. So many medical conditions, anything interfering with breathing, with your heart, with your with your stomach or with your intestine, or with the bladder, may interfere with your sleep. And if you have sleep disorders, especially studied with obstructive sleep apnea, and you have any medical condition, they tend to be more severe and the prognosis is not as good. So sleep does impact medical conditions, and there are many conditions in psychiatry, including anxiety, depression, post-traumatic stress disorder, that are influenced by sleep and are also interfering with sleep. So it goes both ways. The second box at 6 o'clock, drugs and substances. Many medication will interfere with sleep or cause insomnia, nightmares, obstructive sleep apnea, central sleep apnea, hypoventilation, complex behavior. There are many medications with side effects impacting sleep, and there are also substances like caffeine, nicotine, smoking, marijuana, drug streets, which will interfere with normal sleep processes. And there are some medication that will facilitate sleep. So it's going also both ways. There are 80 sleep disorders that have been registered, and any of them may affect patients with EDS, HSD. We'll see a few of those today. MCAS, mast cell activation syndrome, will impair sleep if your breathing path from nose to lungs is affected, whether it's asthma or rhinitis, with or without allergies. It will interfere with the quality of sleep. If you're having digestive issues because of MCAS, it also impairs sleep. Pain, musculoskeletal issues, pain from nerve, pain from muscles, from anywhere, will interfere with quality of sleep. If you turn and you dislocate a joint, it's going to interfere with sleep. So all of this will interfere with sleep. Sleep also interferes pain perception. There were studies where they took normal, healthy adults without pain, and then they refrained them from going into deep sleep and sleep, and they woke up with diffuse pain. So sleep is important to control pain. It does not make it disappear, but it helps cope and decrease threshold to perceive sleep. So there are many issues that are relevant, and when you assess sleep in a patient with EDS, you need to think of all those issues and address them all. This is a study from Karen Domani, United States, where she took 65 children referred to her sleep clinic. So it's not a community-based study, but she did a full assessment and a sleep study in the lab for all of them. And what she showed is that 1 in 4, basically, children had obstructive sleep apnea. A little less had insomnia, 22%. 1 in 9 had a circadian rhythm disorder, mostly delayed sleep phase syndrome, which is a condition where sleep is of good quality. It just postponed. So ideally, they would wish to go to bed around 2 a.m. and get up around 2 p.m., which is not very compatible with school. But the quality of sleep is fine. It's just the schedule is off. Periodic limb movement disorder is a disorder where the patients will kick at night. And there is also restless leg syndrome, which is very similar, but occurring at sleep onset when they are awake. Both conditions were prevalent, were common in 16 and 7% of patients. One interesting point, and we'll come back to this, is that many of them had central hypersomnia, a disorder of central hypersomnolence, including 10% narcolepsy and 5% idiopathic hypersomnia. Those are very high numbers, and we'll come back to it. 1 in 4 did not complete the whole follow-up, so we don't know what are the diagnoses, and some had disturbed sleep, but the sleep study was not diagnostic, and they did not perform a second sleep test. So this is one of the studies where they looked at all the sleep disorders at once in a small, in a good sample of 65 children, but it's only those who were referred to sleep clinic and not all of the children with EDS, hypermobile EDS in this group, who would have been in EDS clinic. What is obstructive sleep apnea? Obstructive sleep apnea is a very common condition. We estimate the prevalence between 5 and 20%, depending on the test that is performed or on the criteria that is used. The International Classification of Diseases by the World Health Organization divides sleep-related breathing disorders into 4 categories, obstructive sleep apnea being by far the most common, and it does include upper airway resistance syndrome, which was described back in 1970s, but it's very relevant to this group because this is one of the conditions that we might see the most often that is peculiar in particular to women. So this is what we'll discuss the most. Central sleep apnea is very rare in the general population. However, among patients with HSD or EDS, if you have a Chiari malformation type 1, it is quite classic to have central sleep apnea, even though more often we will find obstructive sleep apnea. Narcotics, baclofen, pregabalin, and gabapentin, those are medications that are either for muscle relaxation or pain, often used, may cause obstructive central sleep apnea and cause also sleep-related hypoventilation, which is a slowing down of the breathing to the point where the CO2 is not expelled out of the lungs. Sleep-related hypoventilation is rare in general, except it's going to be very relevant to kyphoscoliotic EDS. I'm not going to discuss it much further. All respirologists should know about kyphoscoliosis and hypoventilation. So this is a classical management. Though it is also present in some patients with in some patients with obesity, especially as obesity is more pronounced, and in that group, the diagnosis may be missed. Sleep-related hypoxemia is not relevant to this population, so I'm not going to cover it. Obstructive sleep apnea occurs only during sleep, never awake. It may occur at any age from newborns to older individuals. And anyone who is attempting to breathe while sleeping may have obstructive sleep apnea. So you see the tongue in this drawing of half a head, the tongue and the vocal cord. So usually the obstruction in obstructive sleep apnea is occurring in the circle in the back of the soft palate behind the tongue in that area. And it may cause oxygen to decrease or not. Most often it will wake up the brain for a few seconds. The sleeper is not aware of it, and it will occur faster than the oxygen may go down, and then we resume breathing. When we think about obstructive sleep apnea, we often have in mind the obese male loud snorer who stops breathing, who's hypertensive, and whose sleep test will show oxygen dipping quite impressively. And this patient still has sleep apnea. This holds true. Those should be investigated, but that does not represent obstructive sleep apnea in a large group of the general population. Obstructive sleep apnea in general does not cause witness apneas except in rare cases. So this is a misunderstanding that is frequent, to wait until you stop breathing to seek advice from your physician. A lot less recognized presentation of sleep apnea in women, and I would say it's the same for non-obese men, and it's also the same for younger individuals. In this study from 2005, they took men and women, and they took similar weight, similar degree of sleepiness, and similar degree of severity of sleep apnea, and they compare what were the complaints of the men and what were the complaints of the women. So the men would show up and say, I snore, I stop breathing, and I'm very sleepy. I fall asleep easily. Women, on the other hand, showed up complaining of insomnia, fatigue, morning headaches, palpitations at night. They were 2 to 3 times more likely to take antidepressants. And when we probed, are you snoring? Do you have witness apneas? Are you sleepy? They would deny, even though in their tests it was the same as for the men. So this is a major issue because men will be recognized much sooner and sent to the sleep physician. Women will risk to be sent to the psychiatrist or to be treated for insomnia or for depression or for anxiety. So they will be sent to psychiatrists. Furthermore, patients will often complain of choking with awakening in panic. They will have nocturnal sweats, often accusing menopause when menopause is not the explanation, especially if the sweats at night are way more frequent than sweats in the daytime. They will have much more frequently irritable bowel syndrome, migraine, asthma, fibromyalgia, chronic fatigue syndrome, and their sleep tests will not show or not as often the oxygen dips. Typically, they will have obstructive sleep apnea that is causing microarousals or short awakenings from sleep for 3 seconds that will be captured only if you do an EEG. So women present differently. They have different diagnoses and their test doesn't show the same thing. So in summary, for obstructive sleep apnea, there are 2 subtypes. The male obese presentation and the rest of the crowd. So younger individuals, non-obese male, and women in general have more commonly the obstructive sleep apnea waking up the brain. And that is important because it does change the type of test that we need. So why this talk at an EDS conference? This is a study from Gazel where they took 100 adults, 46 with hypermobile EDS, 35 with classical EDS, and 9 with vascular EDS. And they compare them with 100 controls who were the same age and same body mass index, so same degree of obesity. And they did a home sleep test. So we've seen that the home sleep test is much more stringent. And on top of that, they use stringent criteria, 4% decrease in oxygen and not the current 3% decrease. So that will decrease the number of patients we find. So 1 in 3 in his study, 32 to be more precise, had obstructive sleep apnea causing oxygen decreases. 1 in 5, 22% of whom was mild. 1 in 9, 11% had moderate obstructive sleep apnea, and 4% had severe obstructive sleep apnea. The chance of having obstructive sleep apnea compared to the healthy controls was 5 times more common. And if you had sleep apnea, quality of life was lower, sleepiness was increased, and they were more likely to be depressed. This is another study, again, with similar population with different subtypes of EDS, type 2, 3, and 4 from the previous classification. And they took patients referred to the sleep clinic at Stanford. They were 34. And then they compared to EDS patients in internal medicine clinic who were not referred for sleep assessment. But when they compared, both groups had poor sleep, were tired, had fragmented sleep or insomnia, complaints with awakenings, daytime fatigue, everything was similar. The snoring was absent in 1 in 9. The difference was sleep onset insomnia was much more common in those not referred to the sleep clinic. And then they performed an in-lab sleep study, and they showed all of them had obstructive sleep apnea with flow limitation 2/3 of the time. They treated all the group referred to the sleep clinic with CPAP, which is compressed air. We'll come back to it, to the main treatment for sleep apnea, and all were improved at 3 months with a decrease in headaches, better memory and neurocognitive function. They had no more poor sleep. They were no more sleepy, and 29 out of 34 were not tired anymore. This is the paper from 2013 from Guillemino. There is a systematic review with meta-analysis pooled data from all the studies in EDS and HSD, and they reported an adjusted odds ratio. So if you take into account classic, well-known risk factors for sleep apnea, you still have 6 times more likely to have obstructive sleep apnea if you have EDS or HSD. So this is a major increase in the risk of obstructive sleep apnea. Among children, 1 in 3. Among adults, excluding the Guillemino study from just the previous slides, 1 in 3. I believe this is a conservative estimate for adults, as the technology was different and the criteria are not what are recommended nowadays. So how do I know if I have obstructive sleep apnea? So there are steps towards getting a diagnosis and the proper treatment. First, the patient must be aware that obstructive sleep apnea and that they are at risk. This is the goal of this conference. And then they have to decide whether they want to seek expert advice and seek care. And that means also overcoming disease representation. If you're in your mind, obstructive sleep apnea is only for the obese male that is old and you don't fit that picture, it might be hard for you to seek help and to get benefit also from the treatment. So the first thing is to overcome disease representation or prejudice, if you want, against the disease and against the treatment. Until you've tried it, you don't know. Then you need to present with the clinician with the proper information for the clinician to recognize. But again, we have the same barriers. So the physician might not be aware of the association of obstructive sleep apnea with EDS and might not be aware of the presentation of OSA in women and non-obese male. And then you need to be referred to initiate the diagnostic process to finally get towards a treatment. So now you need to seek a medical appointment and see your physician or nurse practitioner and get towards a diagnosis. Say what you want. You want to have a referral to have a comprehensive sleep assessment by a sleep expert, then you need to say so. Quote the statistics. You have 5 to 6 times more high chance of having OSA than the general population, and 1 chance out of 3. List your symptoms. So on the last few slides of this PDF, you will have a whole list of daytime and nighttime symptoms that you can use to present to your physician. I will present to you the Epworth Sleepiness Scale, which is a classic tool we use in all assessment of OSA patients. And I will present to you the Fatigue Severity Scale. There are 2 more questionnaires that I will also discuss. The Epworth Sleepiness Scale, sleepiness, it's much more specific, typical of obstructive sleep apnea, though it is a lot less frequent than fatigue. And as I've mentioned, often patients confuse sleepiness and fatigue. Using the proper word will help you get the proper care. Epworth Sleepiness Scale does not predict whether you have obstructive sleep apnea. You may have severe obstructive sleep apnea on the test and no sleepiness, and the opposite. You may have severe sleepiness that has nothing to do about obstructive sleep apnea. But there's a correlation. So usually the more severe the sleepiness, the more severe the sleep test results, but it's not a perfect association. The score is between 0 and 24. You have 8 questions and you score between 0 and 3 for each question. Above 11 is increased. All the information is on the website of the Epworth Sleepiness Scale. And there are versions in all sorts of languages, so you should be able to find one easy for you. The tool is quite imperfect. The questions are not very clear, and it does not take into account compensation mechanisms like drinking a lot of coffee to stay awake. And it misses some very relevant questions. So you need to mention to your physician whether you fall asleep in class, driving, eating unintentionally when it's inappropriate. We call them sleep attacks, and whether you need naps in your week. I also ask how many hours of sleep the patient has, because if you are very sleepy and you already sleep 11 hours, this is really abnormal. If you're very sleepy, but you don't want to spend the time to sleep and you sleep only 5 hours, it's very different too. And I also ask about the post-traumatic stress disorder and neurostimulants, which are often used nowadays, because those medications will decrease the sleepiness and it might underassess severity of sleepiness in that case. Fatigue severity scale, I believe, is a very useful tool to better understand and measure fatigue. When patients present to fatigue from one patient to the other, it's very hard to compare, whereas here you have an objective number. And as I've said, fatigue is way more common in obstructive sleep apnea than sleepiness. You have 9 questions and a score between 0 and 7, 1 and 7. Minimal is 9 and maximum is 63. Above 36 is significant. I also ask patients, what are the activities that are difficult, impossible, or you have to push yourself to get through at home, work or school, social activities, and family activities. So I need to know how fatigue impairs daytime functioning in all the patients. At times, there are patients who tell me they are fatigued, they are tired, but their fatigue severity scale is normal. So sometimes it's just not measuring what we want it to measure, but most of the time, those patients do not feel refreshed. Their sleep is not restorative. It's a poor quality sleep. And in that case, using the proper words, I don't feel refreshed in the morning, I still feel tired in the morning, is more useful than just saying I'm tired, which is very non-specific. There are many conditions, as you've seen with Dr. Pochinki, about fatigue and medical conditions. So restorative sleep questionnaire, it's a newer questionnaire. It's available online for free, but physicians don't usually use it. It's a good tool so that you can see how your sleep quality evolves with time, normal being around 85, where poor sleepers have rather around 45. Stop Bang is very popular tool that was developed to screen for classical presentation of obstructive sleep apnea, and more specifically, they look for moderate to severe obstructive sleep apnea causing oxygen dips. It does not look for all types of obstructive sleep apnea, and that is a major issue. It will miss mild obstructive sleep apnea causing oxygen decreases, and it will miss obstructive sleep apnea waking up the brain, the one that requires the in-lab testing. It performs poorly among women, non-obese individuals, and younger individuals, and the limits of the tool are not well understood by clinicians. Based on Gazel papers and Francis Chung, who developed the stop bang, if you have a score above 3, your pretest probability of 32% goes up to 62%. That means 62% of those with EDS with a score above 3 have a probability of moderate to severe obstructive sleep apnea. If the score is below 3, so 0, 1, or 2, you still have 17% chances of having moderate to severe obstructive sleep apnea causing oxygen decreases, notwithstanding the mild OSA and the one that wakes up the brain. If we were to say to a patient with chest pain, oh, you only have 1 chance out of 6 of having a heart attack, I'm not going to do an investigation, that would be very poorly seen by everybody. And the same if you were presenting spitting blood, and we would say you only have 1 chance out of 6 of having pulmonary emboli or lung cancer or pneumonia, that would be unacceptable not to investigate. But that's what we're doing with that questionnaire. And that's why I say clinicians do not understand this tool. From a public point of view, public health point of view, if you have too many patients who are not diagnosed and you want to identify the most severe, it makes sense. But if you're the patient, you have symptoms, you have fatigue, you sleep poorly, and we think that you have obstructive sleep apnea, or there's a chance you might have sleep apnea, blocking the investigation based on the stop bang does not make any sense. On top of that, if you look at Gilmino paper, where everybody had obstructive sleep apnea and everybody benefited from the treatment, it makes no sense, because the probability pretest is 100% and the probability post-test is 100%, no matter what the stop bang result is. So hopefully you've been able to convince your healthcare provider to send you either to see a physician first or to do the test, ideally in-lab testing. If we see you stopping breathing very often, yes, it might be sufficient to do a home sleep test. Choose a lab that is accredited. There are some accreditation in some countries, European and American accreditation, so that they have a higher standard of quality. They need to have a sleep-trained and certified physician available for consultation, which is not the case in many labs that are just offering tests and selling CPAP with no medical help in case there are difficulties. So if your test comes back and shows moderate or severe obstructive sleep apnea, pretty much everybody will agree that you need to be treated, up to 91% agreement. So that should be an easy path. If you have mild OSA, the agreement is much lower, and it's even worse if you have a home sleep test or if you're managed by a family physician compared to a sleep physician, down to 44% agreement with the home sleep apnea test. So some might recommend to lose weight, which we're not against losing weight if you have some excessive weight, except the success rate is 4%. So patients who have obstructive sleep apnea are too tired, and that interferes with appetite, and they eat more, they exercise less. Losing weight is very difficult, and if you have no excessive weight, it's a waste of time. Positional treatment. So we ask patients to sleep not on their back. So that means sleeping on their shoulder, hips, and knees. That's a major issue if you have pain, musculoskeletal pain, and it's a major issue if you dislocate those joints. So you may try it before you visit your physician and say, I cannot tolerate it, I've tried it, or so that you skip that step and not stay in a positional treatment. In my experience, it does not work as well as any other active treatment. Mandibular advancement device, we'll come back to it. And sometimes patients are told, well, it's not severe enough, we're not going to treat it. But it's not the physician who's tired, it's you. And it's not the physician who's wearing the treatment, it's you. So you should try the treatment and decide for yourself whether there are more benefits than inconvenience. And you might need to ask for a trial of compressed air. We call it continuous positive airway pressure to your physician, saying this is a recommendation. And actually, we have the MERGE study that was published by Anita Wims, which was done specifically in mild obstructive sleep apnea. That was a milestone study, as we were lacking good evidence of the benefit in symptomatic patients with mild OSA to benefit from the treatment. And the treatment is as beneficial as in moderate and severe obstructive sleep apnea. The NICE UK recommendation that were published in 2021 also recommended CPAP as first line, including for mild OSA, which was a gap in other recommendations and are still a gap in the official recommendation by the American Academy of Sleep Medicine. So management should be based on the assessment on top of the test. So if the test comes back normal and you have symptoms, if a home test was performed, we need in-lab testing. If the in-lab testing was done, we need to look for REM OSA. We need to look for upper airway resistance syndrome, and we need to look into the scoring criteria, and we need to look into the tracing of the data. And we might need to repeat the in-lab sleep testing. Those are the recommendations from the American Academy of Sleep Medicine. So here is a sample of a home sleep test where in red we have 4 areas where the breathing is very shallow compared to before and after, where we have large amplitude breathing in and out. And in blue, we have the heart rate going up on 3 of those 4 events, showing a reaction, an autonomic response of the heart because of breathing difficulties. So obstructive sleep apnea is a cause of dysautonomia, and it's reversible with its treatment. In this case, 4 events in 4 minutes, if we had the EEG that had documented the microarousal, it would be severe obstructive sleep apnea. But on this test, if this is representative of the whole night, we would say the patient has no obstructive sleep apnea. So that's why looking at the tracing and doing the in-lab testing is important. So how do we treat sleep apnea? The principle of treating sleep apnea is very easy, but it's a complex intervention if we want it to be successful. On the first slide of the drawing, we see someone lying on their back, and to breathe in, we suction air just like a vacuum cleaner would suction the air into the lungs. On the second picture, we have the black arrows showing the suction creates closing of the upper airway, and the patient has a full apnea at that point. On the lowest picture, we have the positive pressure that is delivered through a mask around the nose. And at that point, we push air and we split open the airway so that we can breathe in and out without interruption in the breathing. And to the right is one mass that enters in the nostrils. It doesn't have to be big, and it's a pink one, doesn't have to be ugly either. How to initiate CPAP is important. We used to do in-lab titration for adjustment of the CPAP on all patients. As the pandemic evolved, more and more people adopted the home titration of CPAP. But often we simply give a prescription to the patient and they go and see a CPAP provider. They come back 1 to 3 months later, and then we realize there were issues. We address them. We see them back in 1 and 3 months later, and so on. And I was very dissatisfied with this approach, and I felt that the first experience with CPAP needed to be the best one. And I developed a lab-supervised home testing where I choose the device and not based on the color of the walls of the bedroom. We have protocolized all the difficulties and ask the question to get towards the best solution for every single issue that there might be. There has been also a study where they did a similar protocol supervised by the sleep clinic and showing also improved success rate with this more elaborate system, where in 2 to 4 weeks, I correct all the issues that used to take me 6 to 12 months. So the success rate is higher and satisfaction is higher. So this is a child with a CPAP mask and the headgear. It's rare that we treat children with CPAP, but it does occur, and there are some babies also that we treat with CPAP. Treatment of OSA in children is first line, remove the tonsils and the adenoids. Sometimes we might use CPAP in selected teenagers and children. About the surgery, we do not know whether having EDS impacts the outcome of the surgery. There are no data. Other than other treatment, the mandibular advisement device is a plastic that you wear at night when you're sleeping, and it brings the lower jaw forward. So it puts tension on the jaw, it puts tension on the teeth, which are immobile, and it aims to put under pressure, under tension, the muscles which are hypermobile. So success rate is not that high. I'm very hesitant personally to put my patients on that device, and I really prefer to work and rework with the CPAP if there's anything. Surgeries have not been studied specifically in EDS. The proven benefits are the similar in the general population and in EDS population, according to the paper from Guillemino. So less fatigue, sleepiness, better quality of life, better quality of sleep, better mood, less anxiety studied or proven in women, not in men. Neurocognitive functions are improved. Dysautonomia symptoms will abate, and there will be less headaches, nightmares, improved PTSD symptoms, improve mood. About 55 to 65% of patients have better mood after 2 months of CPAP treatment. And you need to continue on a nightly use if you want to maintain the benefits. So we're changing gear, discussing now insomnia. So insomnia, complaint versus disorder. The disorder needs to fulfill the 5 criteria that are that are projected. The insomnia complaint sometimes, oftentimes I should say, patients may complain of insomnia, but it's not the insomnia disorder. It could be delayed sleep phase syndrome. It could be not knowing what is a normal sleep. Often patients complain of waking up when it's completely normal. So patients need to complain of difficulties initiating, maintaining sleep, or waking up too early. It must have an impact on daytime functioning. You must have a bedroom that is dark enough, a bed that is comfortable enough, decreased light exposure, etc., to allow you to sleep. And it has to be present at least 3 times a week for 3 months to be declared as chronic. Otherwise, it might be acute. And it has to be not entirely explained by another diagnosis. The official recommendation in case that you suspect insomnia disorder is not to perform any sleep test and to go with cognitive behavioral therapy insomnia. So it has been shown that it's effective in all sorts of population, whether you have cancer, psychiatric disorder, medical disorder, no disorders. It can be delivered by a psychologist, a pharmacist, a physician, any healthcare provider, pretty much. It's been effective and demonstrated whether you take it as a teleconference, self-help with someone in person, etc. Sleep Easy is a free cognitive behavioral therapy for insomnia delivered by U.S. Veteran Affairs. And I suggest that you look into it, especially if the physician believes that you should be treated for insomnia disorder. If you've already performed that those sessions, then you may go on to studying why you persist with insomnia despite CBTI. And as a second line, we may add for a short time sleeping pills. So sleeping pills are not to be used in the long term. This is a large study of 1,200 patients with diagnosed insomnia disorder. 3 out of 4 were using on a regular basis sleep aids, either prescribed or over the counter. And 9 out of 10, when they did the in-lab test, had moderate or severe obstructive sleep apnea. That's the vast majority. But remember, we tell physicians don't do in-lab testing, don't do any testing. And we also know now that insomnia is one of the presentation of obstructive sleep apnea. In another study, CPAP was demonstrated to control insomnia in those who also had obstructive sleep apnea in 1 in 3. There are some treatment with more advanced ventilation devices that are better than CPAP in controlling insomnia in those with both insomnia and obstructive sleep apnea. So 2 in 3 success. So we still need psychologists, we still need CBTI, but the question is whether insomnia is a breathing disorder after all. Changing gear, now we're going to discuss central disorders of hypersomnolence. Those are brain-related causes of excessive sleepiness, and you cannot go on to those diagnoses until you have excluded obstructive sleep apnea, including upper airway resistance syndrome. So you need to go through the in-lab testing and the treatment of OSA before we can consider those conditions. So we'll discuss idiopathic hypersomnia and narcolepsy. I will not discuss, but except to underscore the fact that EDS patients are more likely to have traumatic brain injury that are more severe with more symptoms than for the rest of the population, and that is also a cause of sleepiness, notwithstanding the medication that is related to pain in particular and to anxiety that may increase sleepiness. Insufficient sleep syndrome is related to the fact that patients might not know that they need more sleep. So the first thing, if you're sleepy and tired, is yes, to try to sleep longer and see if that helps solve the issue. And hypersomnia associated with mental disorder is not going to be covered today. Idiopathic hypersomnia is a condition where patients usually sleep 12 to 4 hours per 24 hour per day. They have non-restorative sleep. Their naps are not restorative. OSA, obstructive sleep apnea, and narcolepsy need to be excluded. We'll cover narcolepsy next. And it's a very rare condition, 2 to 10 person per 100,000 general population. But Domani pointed that she found 5 out of 100 children with EDS and idiopathic hypersomnolence, which is very high. We perform a test, but that test is not the best. We have issues with reproducibility. That means if we do it over and over, we might get changing results. What is interesting is that in idiopathic hypersomnia, there is dysautonomia. So this is a recent study where they took 160 patients with idiopathic hypersomnia, 26 from their own clinic. So those are the red box comfort patients. And they went to the Hypersomnia Foundation and asked who wanted to participate. And they had a good number of those patients. And 81 controls who are people who were not related to the patients, who were sometimes spouses, friends, and who had no hypersomnia. Among those with idiopathic hypersomnia, 15% were already diagnosed with dysautonomia, mostly POTS. And what they found is that they had moderate to severe, so the confirmed patient, their own patients had moderate in general, and the online patient from the Hypersomnia Foundation had severe obstructive sleep apnea. And they were quite impressed how severe the symptoms were. Those patients were not tested in a dysautonomia lab. It was just a questionnaire based, but it's a validated questionnaire, the COMPASS questionnaire. Furthermore, sleepiness and fatigue were correlated with the degree of dysautonomia. They raised the point that 90% of the patients were women. And then they go on to the discussion, and they do report a French cohort of 62 patients with idiopathic hypersomnia who also had frequently symptoms of dysautonomia, including 32 with orthostatic intolerance, 25 with dysthermoregulation, 46% with cold extremities, 22% with digestive problems, suggestive gastroparesis or dysmotility. 32% had allergies, and someone raised the question of MCAS. 20% had chronic fatigue syndrome. Another study from Busetta, where they performed PET scan, functional PET scan, they demonstrated that there is decreased cerebral blood flow in areas controlling vigilance, how alert you are in the daytime. And the question is, what is their bitin? Are they hypermobile? So nobody has really yet looked into this, but it certainly raises an important question. Narcolepsy is also a very rare condition, 3 out of 10,000 in the general population. Yet Domani, in her case series of children, had 10 out of 100 who had EDS and narcolepsy. Narcolepsy usually begins in teenagers, so in high school, around 15 years old, and they're very sleepy. The teachers believe that they are partying too much, that the parents believe their kids are going to bed too late, but they have a disease that makes them extremely sleepy. Yet, their sleep is restorative. It just doesn't last. So after 3 hours, they need to sleep in the daytime. Their naps are very restorative. They have an abnormality of the REM sleep switch. So the the switch on off is defective, and they may have features of REM sleep occurring in the awake state, which is completely abnormal. So everybody, 25 to 40% of the general population may have from time to time hallucinations related to sleep. So just before falling asleep or just as you wake up, you may see things that are not really in the room or hear things that are not really occurring. But in the case of narcolepsy, it's very scary hallucinations. They may see giant spiders or people who are mean to them, and they often have to wake up their partners and ask, is there someone in the room? Are there really giant spiders? Because they really look real. 70% of the population will have once in their lifetime a sleep paralysis where they wake up and their muscles are paralyzed. Their eyes are fine, their heart and their lungs are fine, they can breathe. But for a few seconds, they will be paralyzed. We almost all have one experience in our lifetime. More common if you have obstructive sleep apnea. And they are sleep paralysis that are very frequent in narcolepsy. They may act their dreams of pursuits and fights. And what is very typical is if they laugh, they may trigger the loss of muscle tone and stay awake. It's not a syncope, but they may fall on the floor as on that picture, and their tone of muscle tone is completely flask for a few seconds. We treat it with antidepressants and neurostimulants. Nowadays, so many patients have it. It's sometimes difficult to know whether they have narcolepsy, and they're half hidden by those medication that will control cataplexy. Interestingly, 50% of adults with narcolepsy will have orthostatic intolerance, and 37% of children too. There are also reports of digestive dysmotility, impaired cerebral autoregulation causing the brain fog and other symptoms. Their eye also have dysautonomia and abnormal temperature regulation. Yet, even though there are evidence of dysautonomia, their sleep is very refreshing, which makes us wonder, is the dysautonomia really causing poor sleep, or is it something else? So hypersomnolence and EDS in those children from the Mani study who were fully studied for their sleep, there's a very high prevalence of narcolepsy and idiopathic hypersomnia. This needs to be validated again, and validated in a larger sample, community sample in adults as well. But as we say, there's an elephant in the room. In this case, there might be a zebra in the room of the sleep physicians, and there might be an overlap in some of the patients from EDS and idiopathic hypersomnia. So I think more research is needed. And the interesting thing is that whether narcolepsy or idiopathic hypersomnia is that there are some other measures and treatment that could be offered to EDS patients if the investigation supports either diagnosis. So there's hope. In conclusion, poor sleep and fatigue are two of the core complaints of EDS HSD population. Sleep disorders and dysautonomia are often found in association, and we know that obstructive sleep apnea is a reversible cause of dysautonomia. Obstructive sleep apnea is common, 5-6 times more common in EDS HSD population than the general population, which is very increased. 1 in 3, and this is conservative, will have obstructive sleep apnea, if not more. Sleep apnea in women is often not recognized. So be aware of that. Be aware of choosing your words properly to get access to a diagnosis and treatment as soon as possible. In-lab sleep testing is preferred over home sleep apnea test. If your home sleep apnea test is conclusive, fine. But if it's not conclusive, you need to go to the more elaborate test. Treatment is not with medication, but with compressed air called continuous positive airway pressure. And there are several sleep disorders that are relevant to EDS population. So thank you for your attention, and hope that we can help you have a refreshing sleep and feel energized all day long. Thank you.